Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of January 30th, 2023. After an update on COVID and the variants, I'll review the pandemic's status, provide an update for those who are immunocompromised, and share a note on drug-resistant gonorrhea. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Here in Alameda County, total cases over the previous 14 days appear to be coming down, as does test positivity. Last week it was at 5%. Positive now at 4%. But unfortunately, when we look at the total number of tests being performed, it's diminishing so significantly that these numbers are really becoming quite a bit less reliable. Just to give you an idea, the rolling 7-day average number of tests performed is currently only at about 1,500 tests. And by way of comparison, at this time last year, it was at about 25,000 tests. So we can keep looking at trends, but these are not the indicators that they once were. Hospitalizations are still trending downwards, with 112 in the hospital, 8 of those in the ICU with COVID-19. Looking at our wastewater data is not quite as reassuring. Here we see a clear uptick from January 12th through the last day that we have reported here, which is January 24th. So clearly this is heading up. And remember, this is the earliest indicator we have, and it may now be the best indicator we have since we can't really rely on testing anymore. So this is certainly a cause for concern, and we'll be looking to see whether this translates into increased cases over the coming weeks. Daily deaths in the United States appear to have come down a little bit. We're at 477 deaths per day, which translates into over 3,300 deaths per week. And despite what you might have heard in the media, deaths remain a pretty reliable metric to be looking at, even though we know that it undercounts people who may die from a post-COVID event like a heart attack or stroke. But these numbers here do reflect confirmed deaths, and COVID would have to have been a contributing cause for death for it to end up as part of this number. So even though this is likely an undercount, it is still far too high. Looking now at variant proportions, we see that XBB.1.5 continues to increase. I've mentioned CH.1.1 previously just because California noted it here over a month ago, and this variant does have some concerning mutations on it. This is the first week that the CDC added CH.1.1 to the variant tracker because it's now over 1% of the specimens, and that's what you need to be in order to get your own color here. It's currently forecasted at about 1.5% of specimens in the United States at this time. You can see here that CH.1.1 is a descendant of the BA.2.75 subvariant of Omicron. So if you're ever interested in Omicron's family tree, you can see it here on the CDC variant proportion tracker page, which is linked in the post. I think the bottom line of mutations is that we're a bit at the mercy of SARS-CoV-2, which will continue to mutate because that's what viruses do. And hopefully we can just continue to stay on top of it. For now, nothing seems to be competing with the XBB 0.1.5. It has the competitive advantage. It's in the dark purple color here, clearly dominant in the Northeast. And even though it's not growing quite as quickly in other parts of the country, it does appear poised to take over nationwide. So we do have some reassuring signs, but many of them are based on the fact that we're no longer counting and tracking with the same diligence that we were before. And COVID has been quite unpredictable from the start, which has not changed. Now, is the first time I can recall where what we predicted was much worse than what it actually came to be. So that's still being unpredictable, but luckily in our favor. But I just wanted to offer that as a reminder, because just because we got lucky with this winter surge doesn't necessarily predict the future. So continued caution is definitely still in order. Despite this, President Biden has indicated his intent to end the public health emergency on May 11th. The Biden administration had previously committed to giving at least 60 days notice before terminating the public health emergency. So here we have it. So what does this mean? I think the biggest impact here will be that we'll no longer have available free treatments, free tests, free vaccines that are available during the public health emergency. So after May 11th, many people will need to pay for these things, and insurance companies will need to pay for these things. The other great benefit of the public health emergency was that people on Medicaid, or in California, Medi-Cal, on those benefits were able to receive those benefits uninterrupted during the entire public health emergency. The government recently separated this feature from the public health emergency. So beginning on April 1st, governments will resume disenrolling people from Medicaid and doing redeterminations like they did prior to the pandemic. So what this means is that millions of people in the United States are expected to lose their coverage altogether. Others will be terminated and need to re-enroll. So please keep an eye on your benefits. And then even for those who have health coverage, it remains to be seen which COVID-related diagnostics and treatments will continue to be covered benefits. One of the assumptions I think is being made here is that our healthcare system is ready to absorb all of this. So at this point, I would just ask all of you, all of us, to find out after May 11th, where can you get tested for COVID? Where can you get your boosters? Where can you get treatment if you're someone who should get treatment? This might mean asking your primary care doctor, asking your local pharmacist, specifically about what this is going to look like after May 11th and going forward into the future. By all accounts, our COVID support landscape will be changing dramatically. And this, of course, is going to vary state by state and county by county, and even doctor's office by doctor's office. So now would be a good time to do our homework. Now, even though the United States has signaled that it will end the public health emergency, the World Health Organization had a different ruling coming out of its January 27th meeting of the International Health Regulations Emergency Committee regarding COVID-19. The World Health Organization, the committee and the director concluded that COVID-19 pandemic continues to constitute a public health emergency of international concern. And remember, this was the original declaration that signaled that we were in a global pandemic. And according to the World Health Organization, we still are. There are a series of recommendations put forth by this committee, and those included maintaining momentum for vaccination with the goal of 100% coverage for those high priority groups, also improving reporting and better data, increasing availability and uptake of medications and testing, and also importantly, to continue to support research for improved vaccines that will reduce transmission and that are more variant proof, if you will. And if you'd like to read the full recommendations, the link to the statement is in the post. So as it relates to the pandemic status, we're still in a pandemic. Although we can certainly feel optimistic about us faring better so far this winter, the truth is that we don't quite know what is next. COVID has never really been quite seasonal, even though the worst waves have been in the winter time. We've had several surges per year so far, and we haven't really been able to predict more than a few weeks out how big the surges might be and when they're going to be. What we do know is that, unfortunately, SARS-CoV-2 is here to stay. So we have well past the point of hoping to eradicate it. But I think most of us, apparently, including the World Health Organization, aren't ready to call it endemic yet because you don't quite know what's next, and some level of predictability is really required in order to call it endemic. I think we're getting closer. I hope it will be soon that we'll be able to feel like we can really predict when we're going to have surges, how big they'll be, and so on. Here in the United States, declaring the end of the public health emergency is primarily tied to this notion that we have the tools and that those tools can, frankly, be sold on the open market. In other words, the end of the emergency is tied to the commercialization of the pandemic response, meaning government is not going to be footing the bill anymore. And now it's a commercial response. It's going to be up to your insurance or your own resources, just like just like the rest of the American healthcare system. Unfortunately, as the US is declaring the end of the emergency based on having the tools, we're losing tools. On January 26th, the FDA revised the emergency use authorization for Evusheld, which is the monoclonal antibody that gives 6 months of protection to people who are immunocompromised. Evusheld is officially now pulled from the market. It no longer works against the dominant variants that we have here in the United States, so it is not currently authorized for use in the US until further notice. Now, if in the future there are new variants that are again susceptible, then maybe we'll be able to dust it off and resume using it. But for right now, we're no longer allowed to use it. It's no longer effective here. It's still being used in Canada, where their variant proportions look different than ours, but here in the US, it is over for Evusheld for now. In response to this, the CDC put out this infographic, which is supposed to be aimed towards those who have or live with someone who has a weakened immune system. And this is a COVID action plan that looks basically exactly like what we've been saying repeatedly for everyone, not just those who are immunocompromised, because we live on this planet with other people. We should also be protecting ourselves from repeated infection and from the unknowns of post-COVID and long COVID. And also because we work, pray, shop, go to school with people who have weakened immune systems, and we don't necessarily know who they are. So these steps are really the thing to do regardless. Stay up to date on your vaccines, improve ventilation, spend more time outdoors, learn about your testing locations and treatment options before you get sick, and hopefully they won't disappear on you. Test if you've been exposed or have symptoms, wash your hands. And if we're going to say wash our hands, let's also say sanitize high-touch surfaces as well. It's just a good idea for lots of contagions. And wear a well-fitting, and I'll add high-quality filtration mask and maintain distance. So these really are good tips for each and every one of us. And I got to say that this actually seems a bit sad and weak, that this is all we currently feel we have to offer to people with a weakened immune system. The same thing we're offering to everybody else. We haven't heard anything about new monoclonal antibodies on the horizon. Last week, I did go into some detail about a promising potential treatment for those with severe immunocompromise, so you may want to check that out if you missed it, but really we have no idea of whether these will become available, scaled, etc. So while I remain hopeful for new innovations, I am concerned that we're leaving folks behind. Specifically, first, as I mentioned, folks who are uninsured or simply don't have the resources that will be needed to protect themselves from COVID or to treat COVID. And then a group of conservatively about 10 million immunocompromised individuals in the United States who no longer have monoclonal antibody protection or treatment. So as we so-called move on, we need to be thinking about who is being left behind. My last topic, very briefly, is unfortunately, for the first time, there have been infections with gonorrhea and identified in the US that are essentially resistant or have significantly reduced susceptibility to every antibiotic we have for it. So over the last few years, we actually have seen increasing numbers of several sexually transmitted infections, including syphilis. But this is the first time we've seen such multi-drug resistant gonorrhea in the US. 2 cases were recently identified in Massachusetts, and these 2 cases apparently are not related to one another. So you can pretty much bet this means that there's other cases. And I think what this highlights is an issue that, first of all, we have lots of infectious diseases that we need to be continuing to have vigilance around. But also this bigger issue that there aren't really new antibiotics in the development pipeline. Antibiotics don't make much money for pharmaceutical companies. And so it just appears that new bugs may be coming out faster than new treatments in this regard. And drug resistance has already been cited both here in the United States and internationally as a major public health threat. Not only for gonorrhea, but just more broadly, that drug resistance is something that we have to be vigilant about, because once we run through our antibiotics, then we can end up in a situation where we can't treat infections that we used to be able to treat. So hopefully, the drug manufacturers and our governments are paying attention to this and are investing in new antibiotics in the pipeline. Also, hopefully, our public health methods of case investigation and contact tracing will help to get to the bottom of the cases that are currently in Massachusetts and help us understand how widespread the issue might be. So this is something that we'll continue to keep an eye on, but I think the general take-home message here is protect yourself. And if you haven't been, get tested. And please, if you don't have a primary care provider, get one, know how to reach them before you need them. Stay up to date on your preventive healthcare maintenance and all of your vaccines. Please do what you can to avoid getting infected or reinfected with COVID. Each infection is another opportunity, not only for a bad outcome, but also for a post-COVID event like heart attack or stroke, or for long COVID. Remember to eat a balanced, nutritious diet, get some exercise. Unless you're sick with COVID currently or you're fatigued post-COVID, in that case, we want you to get your rest. It just may reduce your risk of more severe or prolonged long COVID. Manage your stress levels. Consider a multivitamin supplement and additional vitamin D, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.